Yes, good day, everyone. Thank you so much for joining us for this webinar titled Routine Data Use and Evaluation of Practical Guidance. My name is Eva Silvestre, and I am at Tulane University and work also with Data for Impact. And so this is just going to be an overview of an activity that we have conducted over a course of a year, exploring the use of data, using routine data and evaluations. We have used guidance from our past experiences under measure evaluation, working to improve routine health information systems, as well as our experience conducting research. And so again, just an introduction. So the activity took place over the course of a year that began with doing a literature review of all different types of routine data use and evaluations. And so I'll talk a little bit more about that. I'll also highlight some of the key points from the guidance in terms of lessons learned from doing this activity and looking over, the ways that routine data has been used in evaluation, and looking at some kind of practical considerations because people are coming from different levels of expertise and knowledge when it comes to using routine data and even knowledge of routine data. And then we'll have a couple of examples of two of the technical briefs that were conducted, one from Ukraine, which will be presented by Zola, and one of an example from Kenya that will be presented by Lyubov Teplitskay. And then at the end, we'll have room for questions. And I see already that the Q&A already has some questions in there. That's great. But we're going to ask that you put all your questions in the Q&A, and then we will answer them at the end of the presentations. And then if any questions that do not get answered, what we're going to do is we're going to download the questions and provide written response, which will then also be shared with all the participants. So with routine data sources, we know that routine data sources are, data that are collected at regular intervals at both private, public, and community level health facilities and institutions. And here, this table that was created for a measure evaluation document, you can see the different types of routine health information systems that go from, the individual record systems that include, paper-based records of patient care, as well as electronic medical records, to service, record systems and resource record systems. So there's, quite a bit of data sources that are qualify and fall under routine data sources. However, there has been a lack of confidence in routine health information systems overall, kind of citing kind of issues with data quality at different levels of the healthcare system. But we also know, though, that over the last, 20, 15 years, there's been a lot of interest, and USAID and other donors have made significant investments to improve these systems through a wide range of interventions. So this is everything from, harmonizing of indicators, to setting up technical working groups, to facilitating the implementation and rollout of DHIS2, electronic health record systems, et cetera. Data quality audits, data quality reviews. So lots of different interventions have been implemented to improve routine health information systems. In evaluation, again, historically, routine data had been passed over by evaluators in favor of other options, such as standalone surveys tailored to meet specific evaluation objectives. But primary data collection is expensive and can be very time intensive. And depending on the types of research questions that are being asked, some of these questions might be answerable with routine data sources. And so we're seeing a change and a shift here with increased availability of routine data, the perception of its cost efficiency, and the complex nature of health interventions being implemented has led to increased use of routine data and evaluations. So our approach for this activity to kind of take a closer look at this began by reviewing evaluations that were conducted by measure evaluation using routine data. And then we conducted a literature review to identify additional examples of studies that use routine data. And then we selected 18 evaluations for further investigation based on the type of evaluation design that was used, the source of data, and the health area being evaluated. And then the idea here was to develop these technical briefs that looked at different aspects of the process and experience of using routine data. So here, we weren't necessarily interested in the overall results of the evaluation, but we were interested in the process of using the routine data. Whether, everything from accessing it to cleaning it to other, issues that were encountered with using the data. And so we focused on 13 briefs whose original authors could provide further information. So we started off with 18, then we were able to communicate with 13 different authors to complete and finalize these briefs. And here are just some examples of some of the technical briefs that were developed under this activity. The website is also here where you can find and download all of the different technical briefs as well. And as I mentioned, 2 examples will be presented in this presentation as well. So just kind of going through just some of the kind of lessons that we took from doing this type of activity. It all begins with understanding routine health information systems of the country or countries of interest where you want to do the evaluation. It is very important to know, how data is being collected, transmitted, aggregated, and used in the particular country. It's very important, of course, at the beginning to know what the process is for getting permission to access data. And we, collectively had many different experiences in accessing routine health information systems data, everything from it being very easy and getting permissions right away to taking, months and months of kind of going back and forth to making sure that we have access to the data. So that's something that we can't overlook, is just how lengthy the process can be in accessing data. And then, it's important to be familiar with the RHIS of the country. So, we suggest looking for foundational documents such as HIS strategic plans, annual health statistics reports, core health indicator reference sheets, and PRISM assessment results and DQA and RDQA results that may have been conducted in the country. The RHIS context, of course, is also going to be really important. HIS across the world have evolved in unique ways, and so even where there may be kind of common interventions, the actual context in which these exist is going to be really important. The history as well of the RHIS is going to be important, especially even evaluation is going to cover a long time period. And so we have to really kind of consider, contextual factors that can affect data collection during our evaluation time period, such as disease outbreaks like Ebola or COVID-19 at the present day, natural disasters, labor disputes where data might be withheld to extract concessions, and violent conflict. So you need to be familiar with these contextual factors if you're going to be using routine health data. And so some important context questions include, have there been any changes to the way the indicators of interest have been defined? Have there been any changes in the way that data has been collected? And we'll talk about this in one of our examples about this shift from paper-based systems to electronic systems can create some obstacles if you want to use the data for evaluation. Have there been any changes to administrative alignment during this time? We had experiences where districts were redrawn, right? And so that shifted and affected overall data availability. Are there any expected changes to administrative alignment during the evaluation? And then, of course, understanding if there have been contextual disruptions that may have affected service delivery, availability of required commodities, et cetera, like vaccines or therapeutics. So it's also important to understand specific data sources. Here I have some examples, of course, of kind of a paper-based register, then shifting, to kind of an electronic data collection system. So data sources will present their own opportunities and challenges. It's also important to remember that RHIS are set up to meet a country's information needs and not set up for research or evaluation. So again, the data may be available, but it's not necessarily available in a way that it's easy for researchers to access and use. Some challenges encountered, of course, are case-based systems versus visit-based sources, the ability to extract data for analysis, the presence or not of unique identifiers, and this is going to be important if you want to be able to link services or to kind of track people over time. And also the interoperability of multiple data sources or of older and newer systems. So again, there might have been an electronic system 8 years ago, but now there's a new electronic system. Are those systems able to talk to one another? So that's something to an important consideration. Data quality, of course, as I mentioned, there's been lots of different concerns about data quality, but there's been a lot of efforts to improve data quality as well. Here I'm just showing you the data quality review tool that is available at the World Health Organization website. So there's been a lot of tools that have been developed to look at data quality that are also important for researchers to look at so that they know what are some common metrics and dimensions of data quality to look for when you are using routine data in evaluations. Data completeness, of course, is also going to be one component that is going to be important. And so, it'll be important to know and understand reporting deadlines, review internal data quality reports, maybe if possible, conduct your own data quality audit. And so here in this table here on the side, it just shows the kind of reporting lag that occurs, that can occur. And again, this is going to be something that you're going to have to be really aware of if you are, looking to use routine data and evaluation, is that there can be reporting lag for different indicators and for different reports. And so then you will also have to decide what the approach will be to deal with data completeness and data that is missing. And you could ignore, you could exclude districts or facilities, or you can impute. D4I is planning a series of webinars that go more in detail to specific aspects of using routine data in evaluation. And the first one is going to be on using routine data for costing. And then that will be in October. And then in early December, there will be one webinar that will look specifically at this issue of imputing routine data as well. So more information will be available about that. And then other sources of data. The majority of the evaluations that we reviewed used additional data sources, including primary data collection, to answer all the evaluation questions. So the primary data included qualitative methods, and then there was also the use of secondary data, like demographic and health surveys, climatic data, service provision assessment data, et cetera. So so routine data sources were just one part of the picture here in terms of answering evaluation questions. And so the conclusion of our review was that, yes, routine data can be a very valuable source of information to assess health program performance and impact on outcomes. However, there's no perfect solution, and each approach must be tailored to the goals of the evaluation and the nature of the data. And evaluators may need to first assess the data and present a summary of it to donors who want to use it so that all parties are aware of possible limitations. So for the next, I'm going to pass it off now to my colleague Zola Allen, who will give us a little bit more information about the evaluation conducted in the Ukraine.
Thank you so much, Eva. Hello, everyone. My name is Zola Allen. I work for Data for Impact Palladium. And today I would like to share our experiences using routine data and the evaluation of the impact of the TB-HIV integration strategy on treatment outcomes. I'll start with a brief overview of the impact evaluation itself. Then I'll discuss challenges and limitations that we faced in our work, and of course, talk about the benefits of using routine data in evaluation. Next slide, please. But before I go to the main presentation, this slide provides a brief overview, some information about the TB epidemic in Ukraine. According to the latest WHO report, Ukraine is one of the 10 countries with a high burden of the multi-drug resistance TB in the last 5 years, and it's one of the 20 countries with the highest estimated numbers of MDR TB cases. Next slide, please. USAID funded the Strengthening TB Control in Ukraine project, STBCU, and this project had numerous objectives. One of those objectives was to improve the delivery of TB and HIV services with the goal of enhancing the timeliness of care and the life expectancy of patients with TB, HIV co-infection. Next slide. We conducted impact evaluation of the STBCU project. And what we aimed to do, we examined the relationships among strategies for integrating TB and HIV services and the use of TB HIV services. Also, we looked at the relationship among strategies for integrating TB HIV services and mortality outcomes. And for this impact evaluation, we employed a mixed methods approach. It was a quasi-experimental quantitative evaluation design complemented by qualitative interviews to inform the findings. For some of you who are not familiar with the TB and HIV integration, when I talk about integrating TB and HIV services, it's basically providing this both services in the same location and at the same time. And for this evaluation, we had baseline, we had endline, we worked in 6 different oblasts, 3 comparison and 3 intervention oblasts in Ukraine. And overall, we worked on chart abstraction of almost 6,000 records. Next slide, please. These are the 3 questions that we addressed using routine data. The first question was, what proportion of TB and HIV/AIDS patients completed each step in the cascade of services, from screening to receiving treatment per national protocol? The second question that we had was, do service integration, training, and support between TB and HIV/AIDS services decrease the time lag between each step of service, such as screening, testing, and dispensing treatment for TB and HIV/AIDS patients? And the last question was, do service integration, training, and support between TB and HIV services decrease the all-cause mortality among the TB/HIV co-infected patients? Next slide, please. The primary data source was patient medical chart from which the data were abstracted retrospectively. And in general, what we can say that the usability and quality of data were sufficient to address the evaluation questions. Thus, all medical chart data aligned well with the evaluation period, and we were able to use abstracted data from routine data sources in all 6 study oblasts. Next slide. In the next few slides, I'll be discussing challenges that we faced in the usability of routine data for the evaluation. First, I'd like to talk about the way how data were captured in electronic registers. So electronic registers contain information by case, not by patient, and some of the patients had numerous cases. So what we had to do, we had to deduplicate data and include only the latest case in the sampling frame. Another issue that was related to the way how data were captured was that in the AIDS centers, patient lists included all HIV patients that were registered, including such groups such as those who were diagnosed with HIV within the penitentiary system. So we had to exclude some of the patients who did not receive treatment in the AIDS centers. Next slide, please. Another challenge that we faced related to data availability, we faced the issue of missing data in both TB facilities and HIV/AIDS centers, and it was on data related to HIV disease characteristics as well as data on TB disease characteristics. And for example, at the AIDS centers at the baseline, over 50% of co-infected patients had data missing on number of visits, clinical stages, and CD count. And while this situation with missing data improved by the end line, we were not still able to use this because the analysis that we conducted, it was survival analysis using Cox proportional hazards models with a difference in difference approach, and we model the impact of the program on all-cause mortality. So for this type of analysis, we had to have all these characteristics at both baseline and end line. So for this, in this particular case, some of the variables we were not able to include. And the same relates to this drug user variable. This variable was self-reported by patients. And if the patient during the visit mentioned his or her IDU usage, then it was recorded. If not, it was not recorded. So we had to work with what we had. And it was a lot of missing data on this variable. Next slide, please. Another challenge that we faced was related to data accuracy. As you can imagine, our data involved a lot of dates because it was about dates and time lag between each step of services. And there were cases when the dates of service were incorrectly recorded according to the expected time sequence. So sometimes the date for diagnosis was recorded before the date of screening, and we had to do a lot of data cleaning to fix these issues. Next issue here that I'd like to talk about is about the low variability in some of the variables. In particular, if we look at the analysis of the number of planned and received doses of treatment, very often these numbers were the same. And there were cases where these numbers did not correspond to the duration of treatment. They were lower than what we would expect. So due to this low variation in the proportion of doses completed, we had to drop this particular variable, and we did that with other variables as well. Next slide, please. This challenge relates to the inconsistency in the use of data collection tools across health facilities. As I mentioned, our baseline data collection and then end-line data collection, they took place at different years. So the baseline took place in 2014. The end line took place in 2016. One of the instruments that we used was HIV control card, and this instrument was modified in 2012. However, not all facilities were using the modified form. And for us, it was very difficult, almost impossible to find out which version was used by each facility. And while some of the codes in this form were the same, other codes changed between these two forms. So if we look at this T6 code, it was treatment completed in the first version of the form, but then it was changed to requires preventive treatment, which are different things. So what we ended up doing is just for all T6 records, we went to each of the patient's records and looked at previous visits. And if in the past the patient was diagnosed with TB, we used this T6 as treatment completed. Next slide, please. This challenge is about missing data. At the baseline, we relied primarily on paper records. At the end line, we relied on both electronic and paper records, but we faced missing data in both electronic and paper records. To handle this, we developed and documented imputation rules and other decisions on how to handle missing data. And what was really important is that we had to apply these rules and like decisions that we took in both baseline and end line phases of the evaluation. Next slide, please. Well, that was a long list of challenges. Now let's discuss limitations in using routine data for evaluation. As you know, when we work on evaluation using data, we are constrained in our analysis to the variables that are available from the records. And in our particular case, data from the records were better suited for the analysis of service cascades, which was the second question that we addressed, then for analyzing the effect of services on survival. Next slide, please. And as Eva said, it takes time still, like primary data collection takes time. For us, using routine data was also time consuming. It was a lot of labor and time that our data collectors had to spend. First of all, sometimes it was difficult to find necessary medical records in the archive, so data collectors went to a health facility. And then in health facilities, they had to go to an archive, and then archive could be located in another health facility and another rayon, which is like local setting. So it was time for travel, it was time to getting to the physical paper records in order to do chart abstraction. Also, TB forms were not always kept with forms containing HIV-related information due to confidentiality reasons, and our data collectors had to go to do different locations to get both forms for chart abstraction. And this item is about intensive and follow-up treatment being provided at different facilities. For some of you who know, the intensive treatment is in Ukraine is provided in large TB facilities for the first 3 months. And then patients go for a follow-up treatment to smaller TB facilities. And for our data collectors, to get chart abstraction, they had to go to both of these types of facilities for chart abstraction, which was again time-consuming. Next slide, please. Well, our analysis, we ended up working on samples, separate samples from TB facilities and samples from HIV/AIDS centers. We analyzed them separately. And some patients received services only in TB facilities, some patients received services in HIV/AIDS centers, and some patients received services at both facilities. But there was no unique identification number. And because of the absence of this ID number, we were not able to link these patients between two services. So our data collectors had to do a separate chart abstraction in both these types of the facilities. And as you see in this picture, this is an example of a handwriting. As I said, a lot of chart abstraction was done from paper records, and paper records were not typed, it was handwritten. So this is an example of handwriting. It was really hard to understand what's written there, and our data collectors had to consult with other medical staff or with other colleagues in their team to try to understand the meaning for this handwriting, which again added extra time to our efforts. Next slide, please. Well, let's talk about what worked well. We talked already about challenges and limitations. And what was the beauty for using routine data is that most data that we needed for evaluation were available and they were accessible at the health facilities. We expected most of the challenges related to data collection and data management. And of course, since we expected most of them, we allocated sufficient time and resources to plan our work accordingly. Also, we developed imputation rules and other decisions and documented how to handle missing and inconsistent data. And as I mentioned before, we applied these rules both at the baseline and endline evaluation phases. Next slide, please. And this is a concluding slide, just key points that I want to bring to your attention. First, we were able to successfully use routine data to address all our evaluation questions that we were planning to address using this data. It was important for us to have good planning and detailed documentation, and of course, being flexible while we were using routine data. The development and documentation of imputation rules and other decisions on how to handle missing and inconsistent data were essential components. And the last item here is that from our experience, the use of routine data worked better for some of the questions, those related to service cascades and time gap between services, than for others, such as effect of services on survival. I think this is the end of my presentation, and Lyubov will, yes, please go ahead.
Great, thank you. I'm now going to pass it on to our colleague who's going to talk about the experience in Kenya. So thank you, Lyubov.
Thank you, Eva and Zola. Hi, everyone. My name is Lyubov Teplitskay. I work in health financing at Palladium. Thanks for switching the slide. Today, I'll be discussing the study design and specifics surrounding use of routine data in our evaluation case study in Kenya. This study was conducted under the Health Policy Plus project with my colleague Arun Dutta. Next slide, please. First, I'll provide some background on maternal health and user fees in Kenya. As you can see on the right, the maternal mortality ratio has remained high in Kenya at 342 maternal deaths per 100,000 live births, which is well above the SDG target for 2030. Evidence indicates that the high MMR can be explained by limited access to maternal health services, with user fees and other out-of-pocket payments serving as a significant barrier to maternal health service access, especially among poor populations. Other barriers may include low quality of care received in health facilities, long distances to reach facilities, poorly equipped facilities, and use of traditional practices as opposed to skilled birth attendants. To address financial barriers and access to healthcare, many low and middle income countries have implemented user fee exemption policies. The government of Kenya first introduced waiving policies for user fees in 1990. In 2004, Kenya introduced the 1020 policy, which removed user fees at all dispensaries and health centers for all citizens. Kenya's free maternity service policy was introduced in June 2013, removing user fees for all maternal health services at public facilities, including at hospitals. Next slide, please. So our goal for this study was to assess the effect of Kenya's free maternity service policy on maternal health care utilization and maternal and child health outcomes. We designed our analyses around these two questions, which examine the effect of a policy. Next slide, please. When a policy or intervention is introduced, it can serve as a natural experiment, which allows us to use quasi-experimental methods to evaluate its effect. One such method, interrupted time series or ITS analysis, is increasingly being used to measure the impact of public health legislation or interventions, and is known as being the next best approach for quantifying the impact of an intervention when randomization is too costly or not possible. Traditionally, we've relied on national household surveys to monitor the progress of maternal and child health interventions, and these can include demographic and health, or DHS surveys, and multiple indicator cluster surveys. However, these surveys are usually conducted every 5 years, which do not make them an ideal data source for analyses that require time series data. So routine data is optimal for use in time series analyses since they're collected frequently, giving these data an advantage over more infrequent surveys. In our case in Kenya, we use data collected through the District Health Information Software version 2, or DHIS 2, as monthly data points for ITS. Next slide, please. Some features of ITS are summarized here on the left. In an ITS study, a time series of an outcome of interest is used to establish an underlying trend, which is interrupted by an intervention at a known point in time. Through ITS, we develop a counterfactual scenario, and this is the hypothetical scenario under which the intervention had not taken place and the trend continues unchanged. In other words, the counterfactual serves as the expected trend in the absence of the intervention. And this counterfactual scenario provides a comparison for the evaluation of the impact of the intervention by examining any change occurring in the post-intervention period. Effects of the intervention are evaluated by changes in the level and slope of the time series and the statistical significance of the intervention parameters. Although ITS analyses have the advantage of being unaffected by typical confounding variables that are fairly constant across time, ITS can be affected by time-varying confounders that change more rapidly, such as seasonality. Seasonality and other time-varying confounders can be controlled for by including variables representing them in the regression model. ITS analysis results on changes in intervention coverage can be used in tools such as the LiveSave tool or LIST to estimate the number of deaths averted due to a policy, which answers our second research question. LIST estimates the impact of scaling up on maternal, newborn, and child health and nutrition interventions in low and middle income countries. The tool calculates changes in cost-specific mortality based on intervention coverage change, intervention effectiveness for that cause, and the percentage of cost-specific mortality sensitive to that intervention. The coverage data can come from large-scale household surveys, such as DHS. And this particular tool has been used by NGOs, government partners, researchers, and project planners for advocacy, evaluation, and strategic planning. It's housed within Spectrum, a software maintained by Avenir Health. Next slide, please. The DHIS2 outcome indicators that we use to assess maternal and child health service coverage are included here, and they mainly include outpatient service use among children, antenatal care visits, normal deliveries, and postnatal care visits. Public, private, and faith-based organizations report into DHIS2 in Kenya and were included in the analysis. We aggregated all monthly national level data from all 47 counties in Kenya for the analysis. Next slide, please. In most countries, DHIS2 data are derived from paper-based recording and reporting at the facility level. The monthly facility reports are then sent to the district health office where the data are entered into DHIS2 and uploaded digitally. Some facilities, such as hospitals, enter the data directly into DHIS2. So for this reason, it's important to assess the quality of the numerator of the coverage indicator by analyzing completeness of reporting and consistency across time. For our study, we looked at reporting rates for specific coverage indicators and did not consider using indicators for which data was incomplete. We removed outliers using the box plot method. Outlier values were replaced with the mean value and observations, excluding all outliers. And since we know seasonal factors influence healthcare use, specifically maternal and child healthcare use, we adjusted DHIS2 raw data for seasonality prior to conducting ITS analysis. We also examined facility reporting rates, which improved in Kenya from 2011 to 2015, with average reporting rates exceeding 75% for all facilities in 2014. We addressed any facility non-reporting by making assumptions on performance of non-reporting facilities using an adjustment factor based on comparison with Kenya DHS data. Next slide, please. Our analysis spanned the period January 2011 through August 2015. So we looked at the 2.5-year period before the policy was first introduced in June 2013, and then the 2-year period after the policy was introduced. In the regression shown here, Y is the value of the coverage indicator of interest. Time is a continuous variable ranging from 1, the start of the period, or January 2011, to 55, the end of the period, July 2015. An intervention is a binary variable with the period before the policy intervention coded as 0 and the period after coded as 1. So here in the regression, we have the intercept term, or the starting level of the outcome variable at the beginning of the period. Beta 1 captures the trend of the outcome variable before the intervention, and beta 2 captures the change in the level of the outcome after the intervention, and beta 3 captures the slope change in trend for the outcome after the intervention. So our ITS utilization results are used as inputs in lists to estimate number of maternal and child deaths averted due to the intervention. If we had not accounted for a counterfactual situation, the results of the list analysis would be a projection on how many deaths were averted from 2013 to 2015 compared to the situation where coverage of all health interventions remained the same level as 2012. So we developed a counterfactual projection to account for the pre-policy coverage trend had the policy not occurred, assuming that there were no additional external factors affecting the trend other than the policy intervention at hand. We projected the counterfactual coverage of interventions and lists using the initial trend of indicators revealed in ITS analysis. By subtracting the counterfactual numbers from the real world numbers, what remained was the number of neonatal and maternal deaths averted specifically due to the policy. Next slide, please. Incomplete facility reporting and lack of alignment between DHIS2 intervention coverage and list service coverage were two important limitations that we faced in this analysis. In addition, since not every health facility in Kenya reported to DHIS2, we had to assume that the facilities included in DHIS2 were nationally representative. As you can see from the table here, DHIS2 does not report all possible maternal and child health utilization or coverage data. So we had to make several assumptions in order to translate the DHIS2 data into national coverage of interventions used as inputs in the list analysis. So you can see skilled birth attendants and clean postnatal practices are inputs in lists on the left, and coverage of these doesn't necessarily align with coverage of the corresponding DHIS2 indicator, normal delivery. So we needed to generate estimates for list inputs using coverage via DHIS2 indicators for the period, using other data from DEMPROJ and Spectrum, and using data from the Kenya DHS 2014 report. Next slide, please. So here's a more specific example of how we estimated list inputs based on the coverage estimates obtained using ITS and DHIS2 data. We assumed that the list input for clean postnatal practices was equivalent coverage to coverage of normal delivery at a facility. However, coverage of normal delivery at facilities may not necessarily equal coverage of skilled birth attendants. Data from Kenya's DHS, which includes coverage estimates for both health facility delivery and SBA, can be used to translate DHIS to normal delivery coverage into an SBA estimate. So we use the following calculation where HFD is the coverage of health facility delivery in year T, which is the sum of normal deliveries in that year, divided by the total number of live births as estimated by DEMPROJ and Spectrum. And then the coverage of skilled birth attendants for time T is then coverage of health facility delivery plus a factor F at the time T, which is the estimated difference between SBA and health facility delivery from the DHS for 2008 and 2014. Next slide, please. So to conclude, at a high level, we found that removal of user fees for maternal health services was associated with health utilization increases at MOH facilities and decreases at faith-based organizations and private for-profit facilities. Routine data, such as the DHIS2, can be useful to examine a policy's influence on healthcare utilization trends, because this type of routine data provides a time series data set or continuous sequence of observations. Facility reporting rates are also improving in countries, which is encouraging for analysts of routine health data such as DHIS2. There have also been approaches developed by researchers to correct for any incomplete facility reporting as well as data quality issues, which I noticed is a very hot topic in the questions in the chat box. So we're happy to link participants of this webinar to some of those resources to help with some of these challenges. And lastly, as our study illustrates, aggregate DHIS2 data from facilities can be used not just to assess differences in healthcare coverage following an intervention, but also as input into tools such as lists to estimate impact on mortality, And this can serve as particularly useful evidence for policymakers to assess the impact of policies on population level health outcomes. Thank you.
Great, thank you so much. So in the remaining 13 minutes or so that we have before the top of the hour, we're going to try to go through as many questions as we can. And as I mentioned before, any unanswered question, we will provide written responses to. So let me just go through here. So just the first question was the brief explanation of PRISM, RDQA, RDQ. So these were tools that were developed. PRISM was done to kind of measure overall performance of a routine health information system. And so the DQA is data quality assessments, audits, I mean. And so these are, again, tools that have been developed to monitor the kind of internal data quality. And usually what these involve, facility visits where you check, indicators that have been reported to, the central government against the indicators that have been collected at the health facility level. But basically they're tools to assess the quality of routine data. Let me see. So let's see. Zola, there's a question here if the data in the Ukraine evaluation was collected by medical professionals.
In our data collection in Ukraine, we worked with our partner, IFAC Institute, and IFAC Institute had data collectors who were medical staff. So they worked in health facilities. We hired doctors actually to work on chart abstraction. As you imagine, it's a lot of medical terms, so it requires medical degree to be able to work on chart abstraction.
Okay. There's another question too about the Ukraine evaluation. Did you have objective benchmarks for data quality to help you make the decision about whether or not to use the data?
Well, first of all, before we even started data collection, we developed our tools, our instruments, and we tested them to make sure that the data that we would like to collect are actually available in the records. And then when we already collected data after all the field work, etc., for each of the variables, we reviewed the completion, the extent to which data were completed. And of course, if you see the missing data, which are over 50%, we'll not be using it. There is no way we will be imputing data with so much missing data. And in general, from my practice, if I see something more than 30% missing, I would basically not work on imputation.
Thank you. Lyubov, there's a question here about the Kenya National Health Service survey and why it was not used to adjust the assumptions. Did you use it at all or consider it?
Thanks for that, Eva, and thanks for the question. We did not need to use it because our estimates were focused on service coverage and the data was available through the DHS 2014. The SPA referenced is from before the study timeline, so we did not use it now.
Okay.
I'm also happy to answer another question, I think from earlier. Juan Carlos asked like a more general question and about basically the levels of the health system where we have strongest evidence of using routine health data. Data quality is a concern by many stakeholders. I just wanted to comment on this because I think routine data quality in countries largely depend on the country and the country's commitment to its routine data information systems. So in Kenya's case, the health ministry, both at the national and county levels, has a strong commitment to the health facility reporting system. And in Kenya, it's mandatory that all programs use this same system for collection of facility-based indicators. So there's a lot of interoperability in the system, and this is why Kenya has seen a lot of success in improving the data quality of routine health system data. So just wanted to comment on that one.
Great, thank you. Zola, there's a question again about the Ukraine study. Just were all patients co-infected with TB and HIV, or you couldn't ascertain that because there were no unique numbers?
Oh no, that was not the case. We had a separate sample for patients who were just having TB. Another sample we worked with was the patients who had only HIV. And then we had a sample of co-infected patients. And we oversampled that particular sample because of our question on the mortality outcomes. So we worked with separate samples, and that was a different sampling strategy for creating each of these samples. And it was just, there was another question here about numbers. It's just huge numbers. As I said, it's almost 6,000 total. And like for TB facilities at baseline, we had 1,500, and then end line again, 1,500. And 8 centers, we had 1,100 at the baseline and 1,500 at the end line. So it was a huge effort, massive effort for data abstraction.
Can you also talk a little bit about your own data collection tools that you created for the abstraction? Because here there's a question about, did you have to prepare routine data collection tools during the planning stage of the evaluation?
Yes, we had to prepare our data collection tools, and for each of the type of facilities, we had a specific instrument to actually respond to our impact evaluation questions. And all these data collection tools, all the instruments are actually in the annexes of our final report on the study. And this final report on the study is available on the measure evaluation website. If you just do TB, HIV integration, Ukraine, you can find the final report. It's publicly available with all the tools that we have developed.
I should also mention that in the technical briefs that we developed, there's a link to the full, if available, to a full report, right? For all
yes.
Evaluations and research studies that we looked at. Lyubov, there's a question here, if you can answer this about the approach for missing data when using ITS.
Sure, yeah. So I touched on this briefly, and there are more details in the brief we released, but essentially we compared coverage estimates, similar coverage estimates with those in the DHS Demographic and Health Survey for 2014 and made some assumptions. We were able to do this in Kenya because there's actually been journal articles, research released comparing the quality of DHIS2 and DHS data for maternal and child health. And the coverage estimates are actually quite accurate from the DHIS2 data. So we were able to make those comparisons and create adjustment factors where needed based on DHS data for missing data.
And here's a question I think for both of you to consider. And it's about that both of these data sources came from government systems. And so which may preclude private sector data. So how do you think that maybe not including the private sector data skew the findings?
I will just note that the DHIS2 in Kenya does include the private sector and does include faith-based organizations. So it's, at least in Kenya, it's quite inclusive. The rates are a bit lower for private sector, but they have improved them since 2014, and they are considered to be usable now.
And in Ukraine, we didn't have that problem back then. I mean, we didn't face that issue because we worked with large hospitals and we worked with health facilities. data, and that was about the national policy for integrating services across these facilities. So that the issue of using public-private facilities was not in place, and I'm not sure if back then the private facilities were prevalent in the country, because it seems to me that people were using public services for TB and HIV services, public facilities. We have IFAC colleagues here on the line. If you would like to contribute, Tatiana, Olga, please feel free.
Well, there's also another question, and I think it's kind of a good one because, I mean, there's lots of different questions and comments about, you know, that we need to continue working in improving the quality of routine health data as well. And so one question here is that, you know, are stakeholders accepting research using this type of data when there are still, you know, questions on the quality? And I can say that that is always a concern, and that's why, like, it's important to really get your hands on the data before you can fully commit to conducting an evaluation, because you have to be able to say that, like, that there might be, you know, metrics of the quality of the data when it's used for, you know, reporting for the government's purposes, but we have different standards, or we might need the data to be of a different format, for example, when we're doing evaluation. And so that is one of the things that we have really stressed in the guidance document, is that it's really important to actually get your hands on the data before you can really commit to whether or not an evaluation can be conducted. Zola, do you have anything to add?
Yes, I'd like to add here, of course, it's very important to validate your findings as well with stakeholders. So what we did in Ukraine, once we had preliminary findings, we had a workshop with physicians to say, okay, if this makes sense for you, and we obtained a valuable feedback, and we actually modified our analysis based on that feedback. So it's really important to engage the stakeholders in the entire process while you were working on the evaluation.
Yes, thank you. There's one question here that I want to answer. It's about the use of RHIS and propensity score matching to identify control facilities. This is actually something that D4I and Tulane is working on for an evaluation that is being conducted in the Democratic Republic of Congo. We're still in the kind of early stages of it, so there will be more information of that, but we are using propensity score matching as part of the evaluation using DHIS2 data. And I think we have just maybe one more question. Let me see. Just so, Lyubov, do you know if there, for the study that was conducted in Kenya, has it been done in any other country?
We have not done this study in any other country, but we know that ITS, interrupted time series analysis, is being used in other countries to assess the effect of policies. So to use data before the policy and after the policy to understand the policy impact. This is increasingly being used across countries, not necessarily by us.
Okay, great, thank you. Well, I would like to thank everybody for participating. This has been really great, and I see lots of interesting questions. And like I said, we will get back. We will provide written answers and provide those. Like I said, you will be getting a copy of the full recording for this webinar, and then we will also be posting it on the D4I website. But I guess to conclude, like there's a lot more use of routine data in evaluations, and I think it's really important to kind of keep having these conversations and this dialogue so that we can advance the field in this area. So again, I thank you very much, and I hope that everybody has a good rest of their day.
Thank you.
Thanks, everyone.